just start the time that we have for the panel with a brief audience response question. So this is a 65-year-old female, no significant family, surgical, or medical history, gets her first colonoscopy. Her Boston Bowel Prep score is 9, consistent with an excellent bowel prep. You complete the exam to cecum with adequate photo documentation. So a lot of these important quality measures that Dr. Mundowitz mentioned. On withdrawal, 2 polyps are found in the transverse colon, both 5 and 8 millimeters in size, confirmed based on the standardized open snare tool. Really, with a very careful examination, adequate withdrawal time, no other lesions are seen, and the pathology reveals tubular adenomas with no high-grade dysplasia. So based on the most recent Multi-Society Task Force guidelines, what surveillance colonoscopy intervals should we recommend to patients? And so for our audience, what we'd like for you to choose from are the following options. The patient fits Medicare high-risk category, so colonoscopy should be repeated in 2 years with the code listed. Surveillance should be in 3 years, given that 2 tubular adenomas were found. Surveillance in 7 to 10 years, or the patient really doesn't need any more surveillance, as she would be old at the time of her subsequent colonoscopy and the risks outweigh the benefits. So as our audience is thinking about this question and entering their response, Steve, some of the questions that came through as you were speaking really revolve around the first part of your talk, and that is, what can we do as the leader of the University of Colorado GI Division from your perspective to improve screening rates and improve uptake of screening in that kind of large population of patients who currently are not getting screened?
I think it's a great question, and I wish I knew the answer. Having been in this space for many years and working with our national societies, I'm very concerned that there's been essentially burnout of this message, and that people are just no longer willing to pursue the things that we think and I think have been very effective. I think the major efforts that I've seen that have been most effective have been population efforts to get into communities, to get community leaders to essentially organize their groups and get them together. And whether that's through the church, whether that's through the social network, whether that's through a neighborhood association, there are individuals out there that just haven't gotten the message that they really should be screened. We've used, PSAs from athletes and famous individuals who've been touched by colon cancer. All of those seem to help, but it's really, I think, groundwork of getting out into the communities and getting to the individuals and trying to get them to understand. And we have support. We have support from the individuals and the companies that are involved in the screening space to make this happen. We really just need to try to mobilize this. And I think with leaders like you and Jordan and some of the other individuals that are hopefully going to be staying with us and joining our division, we will get together a groundswell and continue this effort.
Yeah, critically important for community engagement. We have the poll answers here. And so it looks like people were tuning into your talk and selected surveillance for 2 sub-centimeter tubular adenomas to be recommended at 7 to 10 years. Can you comment, any further comments on this question and some of the kind of salient points that you brought out in that vignette that make you feel confident that 7 to 10 years is safe for this patient?
Yeah, I think all of us who do colonoscopy are always hesitant because we feel responsible for our patients, and we want to be sure that we've not left a polyp behind or didn't see an area of the colon well. But as we practice more and more high quality colonoscopy, I believe we have to be comfortable with that. And all of us, I think, understand that it requires taking time. It takes time to clean some of the areas of the colon that may not be absolutely pristine. But as you know, the Boston Bowel Prep score is a score that's obtained after you spend time cleaning the colon. And almost everyone can have a score that's very high if you take the time to clean and aspirate. If you get to a situation where you don't feel comfortable, then yes, you should stop and you should ask the patient to re-prep and reschedule the procedure, because an incomplete exam is really not helping anybody, and it does run the risk of complications during the exam if you can't see well. In terms of the 3-year interval, that was the way we had practiced for many decades, and many of us are uncomfortable giving up that 3-year interval, but there's very good data that it does not need to be that frequent. And if you only have 1 or 2 small adenomas with no high-risk features, those patients are really as protected as someone who had a normal colonoscopy. And I anticipate that that interval is going to go to 10 years in the next 5 years.
Yeah, it takes some time for that comfort level and that cultural
Absolutely.
shift. Dr. Yen, one of our chief GI fellows and a budding informatics expert, asks about whether there's a role for quality incentives or maybe even penalties regarding overuse of surveillance intervals. Do you think there's a role for that in kind of a large healthcare system?
Well, I mean, it's a challenge because there are these individual situations where you want to try to address them. And, you know, is it really fun having someone looking over our shoulder with a big stick that is either going to, you know, take money back or, you know, give us a bad reputation for what we do? But I think if we don't follow these guidelines, as you know, the financial situation for healthcare in this country becomes more and more critical, I do think we're going to lose control of this. So I plead with you to follow the guidelines, put them in your reports, make it evidence-based, quote them if you have any concerns, but follow the guidelines as much as you can, because they're going to be enforced eventually. And unfortunately, it will not be pleasant if we rely on the insurers or third parties to enforce them.
Well, we could probably continue this discussion for hours and hours, but I do want to respect all of the attendees and our speakers who have cut out their time on a Saturday to join us today. Dr. Edmundowitz, thank you so much for your time, your expertise, and your unique insights into the topic that affects us all, and that is colon cancer prevention.
Okay. Thank you for including me, and thank you very much for your presentation, because I thought it was very much on target and really helps us understand why we need to expand our screening to that population.
Of course. So I'll now cede the floor to my course co-directors as we close out today's conference.